Bismillahirrahmanirrahim. So, on to the question number 42. A 47 years old woman comes to the office due to a recent change in the mood. The patient says that I began feeling really down about 3 months ago, but I can't think of anything that may have caused this. I'm also much more irritable with my family and friends than I used to be. She has no history of psychiatric illnesses. She also notes that I have been having a lot of problems at work. It is a lot harder to plan and organize my day than it used to be, and I've been missing a lot of deadlines. The patient is very concerned about her symptoms because her father died in mid 60s, 10 years after developing similar symptoms. Temperature is 36.9 degrees Celsius, that is 98.4 degrees Fahrenheit. The blood pressure is 119 by 77 millimeters of mercury. Pulse is 64 per minute, that is kind of low, and respirations are 14 per minute. She is fully oriented, but scores are 24 by 30 on a Montreal cognitive assessment. Normal is more than 26 and it is 24. Losing points on the test for executive function. On examination, she demonstrates abrupt and random jerking movements throughout the extremities and face. Extraocular movements testing reveal a delayed initiation of the saccades, but slit lamp examination is normal. Gait is normal. The patient is unable to maintain her grip on a grip testing. Sensation is intact in the distal extremities. Which of the following is the most likely diagnosis? And the answer to this question is option uh, delta, that is Huntington disease. Educational objective of this question is that Huntington disease presents with a psychiatric symptom, for example, depression, irritability, cognitive impairment, and chorea. Huntington disease is an autosomal dominant CAG trinucleotide repeat expansion disorder with no known disease modifying treatments. Now, here you can see that in this table, in the discussion, clinical features are motor features include chorea and delayed saccades. Psychiatric symptoms include depression, irritability, psychosis, and obsessive compulsive symptoms. The cognitive symptoms include executive dysfunction. Findings include genetic findings are autosomal dominant CAG trinucleotide repeat expansion disorder. Neuropathology, loss of GABAergic neurons, and imaging will show caudate nucleus and putamen atrophy. Management and prognosis, the treatment is supportive and survival is 10 to 20 years. Then the patient's cognitive dysfunction, psychiatric symptoms, chorea, that is abrupt jerking movements that seems to travel from one muscle group to the next, delayed saccades, motor impersistence, that is inability to sustain grip, and family history are consistent with the diagnosis of Huntington disease. Huntington disease is an autosomal dominant CAG trinucleotide repeat expansion disease. Psychiatric manifestations may include depression, irritability, psychosis, and obsessive compulsive symptoms. Because motor symptoms of Huntington disease are often subtle in its early stage, psychiatric and cognitive symptoms may be the earliest manifestations. With no known disease modifying treatment, Huntington disease is inevitably fatal. The death usually occurs 10 to 20 years after initial symptom onset. The choice A, that is depression related cognitive impairment, this was not the option of choice because severe major depressive disorder can present with significant cognitive impairment in elderly patients, often called as pseudo dementia, which may be mistaken for dementing syndrome. This patient's clinical presentation is more consistent with a Huntington disease. Choice beta, sorry, choice beta, that is Frederick ataxia, and choice F, that is spinocerebellar ataxia. None of them were the option of choice because the ataxia, that is impaired smooth muscle coordination, is the hallmark finding of both the Frederick ataxia and spinocerebellar ataxia and often present as impaired gait. It is notably absent in this patient. Frederick ataxia is an autosomal recessive GAA trinucleotide repeat expansion disease characterized by neurological impairment, for example, limb ataxia and sensory neuropathy, insulin resistance, and cardiomyopathy. Spinocerebellar ataxia type 1 is an autosomal dominant disorder that presents with cerebellar ataxia and cranial nerve dysfunction, for example, dysarthria. Choice Charlie, that is frontotemporal dementia. This is not the option of choice because the frontotemporal dementia presents with the executive dysfunction and personality change. This patient's presentation with the chorea and saccades is better explained by Huntington disease. Then the choice eta, that is Parkinson's disease. So it was not the option of choice because the Parkinson's disease is characterized by resting tremor, rigidity, and bradykinesia. The choice gamma, that is Wilson disease, it was not the option of choice because in Wilson's disease, it is an autosomal recessive disorder of impaired metabolism that presents with the liver disease and neuropsychiatric findings. Although Wilson disease may be characterized by prominent neurological and psychiatric findings, for example, dysarthria, dystonia, depression. Essentially, all the patients with the neurological signs and symptoms have evidence of corneal copper accumulation on slit lamp examination, that is Kayser-Fleischer ring. But in our patient, the slit lamp examination was totally normal. Then question number 43 is asking about a 48 years old woman, 48 years old man comes to the office for evaluation of the right foot ulcer that he first noticed 3 weeks ago. He has a history of hypertension, type 2 diabetes mellitus and hypercholesterolemia. His current medication include ramipril, aspirin, metformin, sitagliptin and rosuvastatin. He has a 20-pack year smoking history and occasionally drinks alcohol but does not use illicit drugs. The patient is afebrile. His blood pressure is 132 by 80 mm of mercury and pulse is 76 per minute. Examination shows 1.7 multiplied by 2 cm ulcer on the plantar surface of the great toe. Which of the following tests will best assess the patient's risk for the foot ulcer? And among the given options, the best answer of choice is option ETA, that is monofilament testing. Educational objective of this question is: risk factors for the diabetic foot ulcer include the diabetic neuropathy, previous foot ulceration, valvular disease and foot deformity. Diabetic neuropathy is most important contributing factor and is found in more than 80% of the patients with the ulcer. Monofilament testing predicts the risk of the future ulcer. Then here you can see that this is the monofilament testing performed in this picture. So what do we do in that? This patient has a diabetic foot which can eventually lead to the non-traumatic lower limb amputation. Risk factor for the diabetic foot ulcer include the diabetic neuropathy, previous foot ulceration, vascular diseases and foot deformity. The diabetic neuropathy is most common underlying cause and is found in more than 80% of the patients with the diabetic foot ulcers. Neuropathy decreases the pain sensation and pressure perception. It causes muscle imbalance leading to foot deformities and impairs the microcirculation and integrity of the skin. The neuropathic ulcers most commonly occur in the feet under bony prominences such as metatarsal heads. Under bony prominences such as metatarsal heads, that they typically have a punched out or undermined border. Peripheral sensory neuropathy can be documented by testing for pressure sensation with a 10 gram monofilament placed on the palmar surface at a right angle with increasing pressure until filament buckles. So the patient with the neuropathy have a higher pressure threshold and loss of monofilament sensation, which are associated with an increased risk of foot ulceration. On other sensory deficits may include decreased vibratory sensation, tested with a tuning fork, decreased pinprick pain, or decreased temperature sensation. The choice A, that is over here. So 6-minute walk test, it was not the option of choice because a 6-minute walk test is an assessment of the functional status that measures how far a patient can walk in a standardized time. 6-minute walk test is an assessment of the functional status that measures how far a patient can walk in a standardized time. It is typically used for the patient with a chronic lung or heart disease or with a chronic pain condition. For example, fibromyalgia and osteoarthritis. It is not as useful for the patient with a diabetic neuropathy or for the foot ulcers. The choice beta, that is ankle brachial index. It was not the option of choice because the ankle brachial index, the peripheral artery disease, can be assessed by calculating the ankle brachial index. However, the ankle brachial index is primarily a measure of large vessel peripheral artery disease and does not accurately assess the small vessel disease, which often contributes to the ulcer in a diabetic patient. In addition, the arterial ulcers are usually located on the tips of toes rather than the plantar surface. The choice Charlie, that is capillary refill time. This was not the option of choice because delayed capillary refill time more than 3 seconds indicates impaired limb perfusion and may suggest underlying peripheral arterial disease. However, delayed capillary refill is a non-specific finding and is also seen in the hypotension and volume depletion. The choice delta, that is diabetic neuropathy, that is knee reflex assessment. It is not the option of choice because the diabetic neuropathy can affect large nerve fibers in the lower extremities, causing the decreased or absent ankle reflexes. However, the knee reflex is usually not affected. The next question is question number 44. They are asking about a 65 years old man who underwent right total knee replacement 6 months ago. Total knee replacement 6 months ago comes to the emergency department due to 3-week history of dull pain in the right knee. He has had no recent respiratory illness, diarrhea or urinary symptoms. The medical history is notable for osteoarthritis, hypertension and hyperlipidemia. The patient drinks a beer every night and does not use tobacco or illicit drugs. Temperature is high, 37.3 degrees Celsius or 99.1 degree Fahrenheit. Blood pressure is 120 by 60 millimeters of mercury, pulse is 90 per minute. Examination shows mild swelling and tenderness at the knee with full range of motion. The skin over the joint is intact and the synovial fluid is sampled. The lab studies are as follows. The complete blood count shows platelets 300,000, leukocytes of 9,000 per millimeter cube. There is mild leukocytosis. Synovial fluid shows 10,000 leukocytes and neutrophils are 80%. Which of the following is the most likely cause of the patient's current condition? And among the given options, these options, the best answer of choice was option H, that is Staphylococcus epidermidis. So, educational objective of this question is prosthetic joint infection can be acquired by a perioperative contamination or by extension from an overlying wound infection. Infection due to virulent organism, for example, Staphylococcus aureus presents within the first 3 months with acute pain, fever, and local signs of infection. Infection due to less virulent organism like coagulase negative staphylococci have a delayed onset and present with chronic pain, implant loosening, and gait impairment or sinus tract formation. Now in this given table, you can see that prosthetic joint injection is over there. So time to onset after injury, after surgery. Early onset less than 3 months, delayed onset 3 to 12 months, and late onset is more than 12 months. Presentation. In the case of early onset, the presentation will be acute pain, wound, infection or breakdown, and fever. The most common organism in the case of early onset prosthetic joint infection are Staphylococcus aureus and gram-negative rods. Then and anaerobes can also play an important role. If if there is delayed onset, like there are the onset of symptoms of onset of prosthetic joint infection is happening 3 to 12 months after the operation. So the presentation will be chronic joint pain, implant loosening, and sinus tract formation. The most common organism include coagulase negative staphylococci, propionibacterium species, and enterococci. Then if it is late onset, like more than 12 months, so presentation will be acute symptoms in previously asymptomatic joint and recent infection at a distant site. Most common organism is Staphylococcus aureus, gram-negative rods, and the beta hemolytic streptococci. This patient has subacute pain in his prosthetic knee 6 months after arthroplasty. 6 months after arthroplasty, the synovial fluid analysis shows a mildly elevated leukocyte count with a predominance of the neutrophils. This is consistent with an inflammatory process, most likely a prosthetic joint infection. The leukocyte count in the synovial fluid in the prosthetic joint infection is usually elevated, that is more than 1000 per millimeter cube, but is often lower than a septic native joint, usually more than 50,000 per millimeter cube. Prosthetic joint infection can be acquired by the perioperative contamination of the joint or by extension from an overlying wound infection. Infection due to virulent organisms, for example Staphylococcus aureus, Pseudomonas aeruginosa, typically present within the first 3 months after surgery. Early onset infection with acute pain, fever, leukocytosis, and overall local signs of infection, for example erythema and purulent drainage, not seen in this patient. Infection due to less virulent organism like coagulase negative staphylococci, propionibacterium species, as in this patient, are likely to have a delayed onset 3 to 12 months and present with a chronic pain, implant loosening, gait impairment or sinus tract formation. Fever and leukocytosis are usually absent. Staphylococcus epidermidis in a coagulase negative staphylococcus commonly implicated in the delayed onset prosthetic joint infection. Late onset infection presenting more than 12 months after surgery are unlikely to have been acquired perioperatively and are usually due to the hematogenous spread of a distant infection, for example the urinary tract infection. Then here you can see the choice A, that is atypical mycobacteria. This was not the option of choice because the atypical mycobacteria are rare cause of prosthetic joint infection. They usually cause late onset infections and are most commonly seen in the patient with the immunosuppressive disorders, for example HIV or local trauma. The choice beta, that is Borrelia burgdorferi. This was not the option of choice because Borrelia burgdorferi causes Lyme disease. Late Lyme disease can present with acute intermittent attacks of monoarticular or oligoarticular arthritis with prosthetic joint infection with chronic persistent joint pain is rare. The choice C and F, that is Chlamydia trachomatis and Salmonella species, none of them was the option of choice because the Chlamydia trachomatis and Salmonella species can be associated with reactive arthritis. Reactive arthritis following an initial genitourinary or gastrointestinal infection. Reactive arthritis is characterized by the asymmetric oligoarthritis with urethritis, enteritis, and conjunctivitis. Subacute prosthetic joint infection is an uncommon presentation. Then we have choice D, that was Pseudomonas aeruginosa. This was not Pseudomonas, this is Neisseria gonorrhea. So Neisseria gonorrhea was not the option of choice because disseminated Neisseria gonorrhea infection most commonly causes syndrome characterized by the migratory polyarthritis, tenosynovitis and rash. Acute septic monoarthritis can also be seen, but synovial fluid cells count are usually higher than more than 50,000 per millimeter cube. So the next question is question number 45. They are asking about a 31 years old woman comes to the office after 3 months of continuous burning upper abdominal pain. So there is a continuous burning upper abdominal pain that is only partially relieved by over the counter ranitidine or antacids. She also has experienced recent onset constipation and excess urination. The patient reports no weight loss or uh, decreased appetite. Her menstrual periods are regular. The patient's father has a history of many stomach ulcers and multiple kidney stones. Her temperature is 37.1 degrees Celsius, 98.8 degree Fahrenheit. The blood pressure is 130 by 85 millimeters of mercury. Pulse is 78 per minute and respirations are 14 per minute. Abdominal examination shows normal bowel sounds, tenderness in the epigastric region, and no palpable mass. Her stools are positive for the occult blood. Lab studies are as follows. The serum sodium is 137 millicavernets per liter, potassium is 4.2 millicavernets per liter, chloride is 104 millicavernets per liter. The bicarbonate is 24 millicavernets per liter. Okay, so sodium, potassium is okay, so chloride is alright. Okay, bicarbonate is also alright. Calcium is 11.4, phosphorus is 1.8, blood urine nitrogen is 21, and creat is okay. So additional evaluation is most likely to reveal which of the following. And among the given options, the best option of choice is option F, that is primary hyperparathyroidism. So educational objective of this question is stating that type 1 multiple endocrine neoplasia is characterized. Type 1 multiple endocrine neoplasia is characterized by the primary hyperparathyroidism, pituitary tumors, and gastrointestinal pancreatic endocrine tumors like gastrinomas. Common complications include symptomatic hypercalcemia and recent peptic ulcer. So here you can see that in this given table, manifestations are pituitary adenomas 10 to 20%. Clinical features include secretion of the prolactin, growth hormone, ACTH or non-functioning tumors. Mass effects, for example, headache and visual field defects will be seen. Primary hyperparathyroidism is multiple parathyroid adenomas or parathyroid hyperplasia. Hypercalcemia, for example, polyuria, kidney stones and decreased bone density. The pancreatic gastrointestinal neuroactive tumors 60 to 70%. The tumors are gastrinomas, recent peptic ulcers, insulinoma, hypoglycemia, VIPoma, causes secretory diarrhea, hypokalemia and hypochlorhydria. The glucagonoma causes weight loss, necrolytic migratory erythema and hyperglycemia. The most likely type, the patient most likely has type 1 multiple endocrine neoplasia syndrome MEN1, an autosomal dominant condition that is characterized by the three primary tumors types 3Ps. The parathyroid adenoma, hyperplasia, constipation, polyuria, possibly abdominal pain in the setting of a calcium level of 11.4 mg per deciliter suggests symptomatic hypercalcemia, likely from a primary hyperparathyroidism. Primary hyperparathyroidism present in more than 90% of the patient with a MEN1, usually occurs by age 40 and results from the multiglandular parathyroid adenomas or parathyroid hyperplasia. Gastrointestinal pancreatic endocrine tumors, uh, for example gastrinomas, burning upper abdominal pain that is only partially responsive to the ranitidine and antacids and associated with occult gastrointestinal bleeding is concerning for the Zollinger-Ellison syndrome, characterized by the severe and refractory peptic ulcer disease due to the gastrin producing tumors, for example gastrinomas. And the third one is pituitary adenoma. So there are only three glands which start with a P. So you can doubt parathyroid adenomas, pancreatic adenomas and pituitary adenomas in the MEN1. There is another gland that is pineal that is so rare that you cannot confuse that with any other thing. So 3 P's are associated with the MEN1. The patient's father probably has had MEN1 given his history of the kidney stones, likely due to the hypercalcemia and recurrent peptic ulcers. Choice A, that is adrenal insufficiency. This was not the option of choice because primary adrenal insufficiency presents with fatigue and weight loss. Uh, Typical clinical findings include hypotension, hyperpigmentation, and hyperkalemia. The choice beta, that is glucagonoma. This was not the option of choice because the glucagonoma is a less common tumor in MEN1 and is characterized by the hyperglycemia, necrolytic migratory erythema, and weight loss and anemia. The choice Charlie, that is medullary thyroid cancer. This was not the option of choice because the medullary thyroid cancer is a component of MEN2 and typically presents with a thyroid nodule. The choice delta, that is metastatic gastric carcinoma, it is not the option of choice because the gastric cancer can cause abdominal pain with a gastrointestinal ulceration and bleeding. However, it is commonly associated with weight loss, early satiety, and dysphagia. Would be rare at this patient's age and is less likely to explain the hypercalcemia. The choice eta, that is milk alkali syndrome, it is not the option of choice because the milk alkali syndrome is characterized by the hypercalcemia, renal insufficiency, and metabolic alkalosis. This patient has a normal serum creatinine and bicarbonate levels. The choice gamma, that is sarcoidosis, it is not the option of choice because sarcoidosis causes hypercalcemia due to the increased conversion of 25 hydroxyvitamin D to 125 dihydroxyvitamin D. However, whereas pulmonary symptoms are common, gastrointestinal manifestations, for example, epigastric pain, are rare. Sarcoidosis also would not explain the patient's family history of recurrent kidney stones and peptic ulcer. The choice H, that is thyroid adenoma, this is not the option of choice because the thyroid adenoma, a toxic thyroid adenoma could cause hypercalcemia due to increased bone turnover. However, this patient has no other manifestation of thyrotoxicosis, for example, the weight loss and tachycardia. In the next question, they are asking about, okay, the next question, they are asking about a 46, they are asking about an 80 years old woman is brought to the hospital due to a 3 week of persistent fever, pleuritic chest pain, and productive cough. The patient was seen in the office 2 weeks ago for these symptoms and was given a week-long course of levofloxacin due to a suspected right lower lobe pneumonia. She has a history of type 2 diabetes mellitus and dementia, resides in a nursing home. Temperature is 38.3 degrees Celsius. Blood pressure is 130 by 78 millimeters of mercury and pulse is 88 per minute and respirations are 18 per minute. Oxygen saturation is 96% on the room air. Examination shows decreased breath sounds at the right lower lobe. The chest imaging reveals increased right lower lobe infiltrates, right pleural effusion and right-sided hilar adenopathy compressing the middle lobe bronchus, which is what is most likely cause of the patient's condition. Among the given options, the best option of choice is answer Charlie, that is tuberculosis. Educational objective of this question is primary pulmonary tuberculosis is typically presents with several weeks of fever, cough, and pleurisy. Imaging usually shows a lobar infiltrate, significant hilar lymphadenopathy, and sometimes pleural effusion. Suspicion should be raised in those who reside in the high-risk setting and who have impaired immunity, particularly when treatment for the common pulmonary diseases like pneumonia does not improve the symptoms. Then in this table, primary pulmonary TB, the risk factors are immunosuppressive HIV, travel from the endemic area, exposure to the infected household contact, and resident and employee of the person homeless and shelter and healthcare facility. Clinical manifestations are chronic cough, prolonged fever, weight loss and failure to thrive. The diagnosis is made by positive screening for the PPD or interferon gamma release assay. This is a gold standard now. IGRA test. The chest X-ray is hilar adenopathy, effusion, and consolidation and cavitation will be seen. Positive alpha AFB smear and mycobacterial culture. The treatment is multi-drug therapy, isoniazid, rifampin, paracetamide, and ethambutol. So AFB is acid fast bacilli. Then we have this patient was seen 2 weeks ago due to acute cough, fever, pleurisy, and suspected right lower lobe community acquired pneumonia. Despite treatment with the levofloxacin, a first-line agent, she has persistent symptoms, suggesting an alternate diagnosis. Given her advanced age, diabetes mellitus, high-risk communal living situation like nursing home, and radiographic findings including the compressive hilar lymphadenopathy, suspicion should be raised for the primary pulmonary tuberculosis or TB. Most patients first exposed to TB have an asymptomatic primary infection because the organism is rapidly contained within the granuloma and can become latent if the body fails to clear the bacteria. They are at a risk of secondary reactivation TB later in life. In contrast, about 10% of the adults first exposed to TB develop symptomatic primary disease, progressive primary TB. Risk factors for the primary progression include impaired immunity due to comorbid conditions, for example, diabetes mellitus, renal disease, HIV, advanced age or immunosuppressive medications. Manifestations typically progress over weeks and include fever, pleurisy and cough. In contrast to reactivation TB, usually marked by the cavitary infiltrates, radiography in the primary TB often shows lobar infiltrate due to the unchecked mycobacterial replication and significant ipsilateral hilar lymphadenopathy. Compression of the right middle lobe, multiple surrounding lymph nodes, relatively longer length, and pleural effusion may also occur. The choice A and B, that is lymphoma and sarcoidosis. hilar lymphadenopathy typically detects the infection, for example, TB, neoplasm, for example, lymphoma, lung cancer, inflammation, for example, sarcoidosis. Lymphoma and sarcoidosis often lead to bilateral rather than unilateral lymphadenopathy, and a lobar infiltrate would be uncommon. Sarcoidosis is associated with the patchy reticular pulmonary infiltrates and classically arises in the young adults. The choice delta, that is viral infection. This was not the option of choice because the viral pneumonia typically causes acute symptoms over days and can be associated with the concurrent upper respiratory manifestations, for example, rhinorrhea and sore throat. 3 weeks of progressive manifestations makes this less likely, and patchy bilateral interstitial infiltrates rather than lobar infiltrates would be more common. So we'll keep this section till here and we'll continue from question number 47 in the next session. Until then, Allah Hafiz, fi amanillah, and take care.